Hi, everyone, and welcome to today's webinar, Exploring Trauma-Informed Palliative Care for Populations Experiencing Structural Vulnerability. My name is Naheed Dosani, and we are here on behalf of Pallium Canada. Before we begin today's presentation and understanding that we're all virtually here together, but sitting in different lands across this land, I'd like to start with the land acknowledgement. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Recognizing that I'm sitting in Toronto, Ontario, we recognize that land acknowledgements across this country are an expression of gratitude and appreciation to those whose territory you reside on, and a way of honoring the Indigenous people who've been living and working on this land from time immemorial. It is important to understand the long-standing history that has brought us to reside on this land and to seek to understand our place within that history. Land acknowledgements do not exist in a past tense or historical context. Colonialism is an ongoing process, and we need to be mindful of our present participation. It is also important to acknowledge how Indigenous peoples disproportionately face health inequities and how we have a duty as social and health workers to recognize and address these disparities, meanwhile challenging the oppressive health and social systems within which we work. Today, I'm also standing in for the CEO of Pallium Canada to announce the CPC exchange. The enthusiastic response by healthcare professionals to Pallium Canada's COVID-related webinar series has prompted an exciting partnership between Pallium Canada and the Canadian Society of Palliative Care Physicians, with support from the CMA, Scotiabank, MD Financial, CSPCP, and Pallium have launched a moderated online community of practice called the CPC, which we encourage you to join. The exchange will support interactive online national dialogue between healthcare professionals across Canada regarding the most relevant COVID-related topics in palliative care. The exchange is a professional learning site moderated by members of the CSPCP and open to all health workers, including physicians, nurses, social workers, and pharmacists. There's no cost to participate. Join the exchange now to ask questions about palliative care during the COVID-19 pandemic, to share your experiences, to teach and learn with colleagues from across Canada. And now, just some housekeeping items. Before we begin the discussion, we'd like to note that we are accepting questions via the Q&A section of Zoom. There is a chat section that will not be moderated and reviewed as often as the Q&A section, so please use that. Please feel free to send questions through this mechanism, but please be mindful that for some people, the content that's discussed today can be triggering, and comments you are providing in this area is actually an open space. And at times, such comments or questions can be seen as hurtful or violent, so please be sensitive. Our presenters today are an illustrious group of professionals who I know and deeply respect. My name is Naheed Dosani. Before we move to the presenters, I'm a palliative care physician based in Toronto, Ontario, Canada, and I serve as the lead palliative care physician for the PEACH program, Palliative Education and Care for the Homeless at the Inner City Health Associates. I also serve as the medical director for the Region of Peel's COVID-19 homeless response and work also at William Osler Health System, a large health system in Ontario, as a palliative care physician. I'm affiliated at the University of Toronto and McMaster University. Also, on our panel today, we have Sasha Hill, who comes to us from Toronto, Ontario. She works at the Inner City Health Associates as a coordinator with the PEACH program. We have Rami Shami, who comes to us from Toronto, Ontario, who is a hospice palliative care consultant and comes to us working as a case manager with the Kensington Health Centre. We also have Dr. Kelli Stajduhar, who comes to us from Victoria, British Columbia, through her affiliation at the University of Victoria, where she is a research fellow with the Institute on Aging and Lifelong Health and professor of the School of Nursing. And we also have Dr. Voeuk, who is a palliative care physician coming to us from Edmonton and is working in the Edmonton zone and the palliative care program and serves there as a palliative care physician. In terms of conflicts of interest and declarations, Pallium is a non-profit entity which generates funds to support operations and R&D from course registration fees and sales of the Pallium pocketbook. It's partially funded through Health Canada, and these webinars are supported by an unconditional education grant from Boehringer Ingelheim Canada Incorporated. Our presenters today all do not have any conflicts of interest to declare. The Canadian Society of Palliative Care Physicians is also a not-for-profit entity and is funded primarily by membership dues and the annual conference. They also run a community of practice, which is offered jointly with Pallium and supported through kind contributions via the CMA, Scotiabank, and MD Financial Management. Today, I'm really excited for today because it takes us through a journey, and it takes us through a journey around the world of palliative care, which the WHO defines as an approach that improves the quality of life of people and their families facing the problems associated with life-limiting disease through the prevention and relief of suffering by means of early identification and the treatment of pain and other symptoms, physical, psychosocial, and spiritual. But even within that definition, there are many assumptions about the kinds of lives that people, their environments, and the social factors around them are. In 2018, the federal government via Health Canada set out a new framework entitled the Framework on Palliative Care in Canada, which outlined a blueprint towards a future of palliative care in this country and how it would be delivered, by whom, with specific target and measurement points. The report also highlighted many gaps in care for people from different walks of life and extended commitments to equity and palliative care itself as a fundamental human right. Consider this: a new Canadian Alliance to End Homelessness report released yesterday highlights that 1.6 million people in Canada have themselves had an experience of homelessness. 1 in 10 Canadians can't afford to fill their medications, and nearly 5 million Canadians live in poverty. Further driving these facts home, you can go to a Canadian community and walk just a few blocks and see up to a 21-year difference in life expectancy between poor areas and wealthier areas. Beyond poverty and homelessness, the impacts of systemic racism cannot be forgotten. Nearly 1 in 5 racialized families live in poverty in Canada, and COVID has had a disproportionate impact on Black, Indigenous people of color. Meanwhile, it's estimated that nearly 76% of people have experienced trauma in our communities. From our hospitals to our emergency departments, to our communities and beyond, we see the impacts of social factors on the well-being of people in our communities every single day. This undoubtedly has reverberations on their overall health, but also their ability to access high-quality palliative care. Consider this: people who live in poor neighborhoods in places like Ontario have been shown to be less likely to be able to access community palliative care and home care, so much that they end up in hospital or the ER more frequently. People experiencing homelessness have life expectancies that are nearly half that of the average population. In Canada, life expectancies of Indigenous people are reported to be 15 years shorter than that of other Canadians, and they get palliative care much later in their disease. Ethnic minorities with metastatic cancer are 3 times as likely to receive adequate pain management, and research shows that Black patients are 22% less likely than white patients to receive any pain medications at all. Despite commitments to palliative care at both international and national levels, in reality, palliative care is not accessed by everyone equally in Canada. In fact, through both overt and covert mechanisms, access to high-quality palliative care and the delivery of that palliative care is not immune to the effects of poverty, precarious housing, systemic racism, and other social factors. Yet, we don't talk about these issues enough, and sometimes we don't talk about them at all. That's why it's such a pleasure to be able to moderate today's webinar, which aims to explore the impact of structural vulnerabilities as it pertains to our communities. Our team of expert panelists will explore their personal experiences in a variety of disciplines to detail how certain social determinants of health serve as barriers to care and how trauma-informed care can be envisioned to derive health equity for people experiencing vulnerability. Without further ado, let's get right into today's discussion. As an opening point, I'd like to start the discussion with talking about the concept of structural vulnerability in general. We're gonna go get to meet each of our panelists today, get real intimate and personal with them. So I guess I'd like to ask the question, and I'm sure people are wondering at home, what does structural vulnerability mean to you in your practice? Let's start with Dr. Stajduhar.
So thanks, Naheed. And well, I don't want to call myself an expert at all in caring for people with structural vulnerability, but I have been doing a lot of thinking about it and working in the area for a long time. And I guess where I wanted to start with is kind of, why do we use the term structural vulnerability as opposed to vulnerable and marginalized populations, which is some of the typical language that people use. And it's a language that I use in grant proposals and in practice because it's the language that everybody seems to understand, but it's a problematic language. And it's a problematic language because no group of people is inherently vulnerable. Vulnerability is something that is produced by other people or by systems and structures. So when we talk about people belonging to vulnerable groups, the implication is that they are somehow a deficit. It's an individualized issue. And so that leads us as healthcare providers, I think, to think, we need to fix this vulnerability in somebody without really recognizing that some of those intersecting vulnerabilities are produced by systems and structural conditions. And I think the other, so structural vulnerability to me means that we are recognizing upfront the structural inequities that exist that produce vulnerability in people. And I think, the other thing is that when we look at people and we call people vulnerable people, we actually don't recognize that many of the people that we care about and love actually come with incredible strengths. And so I'm going to leave it at there, but I think structural vulnerability helps to make those structural conditions like classism or racism visible as the root causes of vulnerability. And then we can also look at our own roles in reproducing those kinds of harms to people.
Truth to form, Kelly, you really bring home the point very early that it is about the way we view our world, and structural vulnerability as a definition allows us to see things differently and empower the very people we serve. Sasha, I'm wondering about what structural vulnerability means to you in your practice, because you have a very interesting practice.
Yeah, so in my work in the community, I feel that structural vulnerability is defined as not access mainstream care for one reason or another, whether it be financial, whether it be behavioral, addiction oriented. I think it's just the inability of somebody to access mainstream care, and it's about how we interact with that person and how we manage to gain care for that person outside of like kind of the structural norms. I guess that's kind of my practical evaluation.
That's very useful. Thank you so much, Sasha. Rami, as someone who works as a hospice palliative care consultant, what do you think?
I can't believe I'm in this panel 30 years ago as a hospice volunteer, and I am here with this stellar group. It's really something. I've worked with umpteen hospices over 30 years, folks. And I love what you said, Kelly, about systems and structures. If we truly look at the systems and structures in hospice palliative care, we recognize that hospice palliative care in and of itself experiences structural vulnerability. 40 to 50% fundraise, and then COVID hits, and then where does the money come from to support these programs? And then who ends up in a lack of services or accessibility to services as a barrier because of those financial constraints are the people, right? You have to look at also where a hospice is built, how are they supported and funded. The model itself, it's somewhat of a colonial model that comes from the UK. The people that it serves, the understanding of it. So there's a lot of structural availability in the systems and structures of hospice palliative care that I've had the honor to see over the decades.
Thank you, Rami. Really appreciate it. Dr. Voeuk, what are your thoughts?
Yeah, so I'm really excited to be on this panel as well. And I wouldn't also not consider myself an expert. I think, like Kelly, I've just started to think more about this. And I think I do some work in global and international work in other countries. And in those settings, a lot of them are low middle income settings where they are already at risk for experiencing structural vulnerabilities because of the systems that they live in, because of the political issues, because of the, the economic issues that are happening. And then at times then they experience some of the sometimes health emergencies that come about, for example, COVID, as mentioned, or natural disasters, or conflict and armed conflict, and a lot of things, and enforced displacement as well. So I think to me, there's a lot of those systems that really impact how people do get equitable access to healthcare. And the other thing is some of these places don't actually have existing, or they're fragile healthcare systems. So that's something we also have to consider as well.
Absolutely. So it's one thing to talk about structural vulnerability, and we will take a dive into it, but it's another thing to talk about trauma. And as we do segue, I do want to remind our participants today, thank you so much for joining, that the Q&A section is there. Feel free to drop any questions that you might have if you'd like our panelists to address. So as we kind of segue to talk a bit about trauma has a big role to play in healthcare, and admittedly, of course, palliative care. So I'm wondering, Dr. Voeuk, about your thoughts around how trauma impacts access to palliative care specifically.
So thanks, Naheed. I think it depends on the type of trauma as well, what people have gone through. And I think the important thing is to recognize that, assume that everyone has gone through trauma. Whether that's a single incident trauma, or a complex repetitive trauma, or developmental trauma as a child, or historical intergenerational trauma. So I don't think we necessarily need to know exactly what someone's gone through, but just to ensure that we recognize that everyone has probably gone through something, and we all respond and cope differently. And so I think there are a couple things. One is what has our experience been with death and dying? You know, if you've been in another country, you have maybe seen mass casualty. You may have seen horrific deaths, and that may not be something you want to experience for yourself. And you may have had experiences with authoritative figures or people in power, and again, those systems come into play again, which create this perspective of not the nice or sort of dying well, as we say, or living well. And so that can really impact it. And the other thing is also about availability. So if you don't have availability to palliative care, then it's hard to have access to that. For example, some places don't have availability of opioids. And so how can you access something? And that again comes back to many different factors, political, systemic, economic, that sort of thing.
Thank you, Dr. Voeuk. Sasha, you in your practice see a lot of trauma. How does trauma impact access to palliative care for the people you serve and care for?
I think Dr. Voeuk kind of nailed it on the head there, but I will speak to the fact that the individuals that we serve aren't willing to go back to a hospital setting because of the trauma that they've experienced in a healthcare system. Even one patient in particular, you and I served together, even though we had a great relationship with her, she would only say things when you were out of the room to me. And it was just showing that lack of trust to healthcare professionals based on the trauma that she had experienced, and didn't want to talk to doctors necessarily, even though she had a great relationship with us. It was just a matter of, I don't trust doctors, but I do trust nurses. And that being said, I think another great example, because I love examples because it's practical. We had one patient who we were trying to get PSWs and nurses to come in. We had arranged a lockbox to get into her apartment, and we couldn't figure out why every time we had somebody come into her room, especially when it was dark out, she would become very violent. And once we actually kind of sat down and talked with her, it turns out that she was a residential school survivor, had experienced significant sexual assault. And when someone came into her apartment in the dark, she was reliving that and revisiting that trauma every single time. So once we figured out an actual plan to flick the lights when we came in, and she knew it wasn't somebody who was coming there to hurt her, it made all the difference. It completely changed the way we were able to provide care for her. And I think that is really recognizing the individual traumas, not just trauma in general, but finding out what the individual traumas are and being able to work around them and work with people to make them feel comfortable and provide the care the best we can.
Yeah, the other thing that brings about is sort of the presentations of trauma that we see. So especially in a field that is so often subjective, I know we have objective measures, but we're here to address quality of life. Trauma can present in really different and distinct ways. It can be pain, it can be agitation, it can be not cooperating with a team, or seeming that you're challenging your healthcare team or social care team, for example. Is that something that you see, Sasha, in terms of presentations of trauma?
Oh, absolutely. Like the presentations of trauma are so wide and varied, and trying to actually get down to the base of what's caused key to care to someone. It literally makes a life and death difference.
For sure. And I think sometimes the community within which we work, we sometimes approach things in like a one size fits all approach, and a recognition of trauma allows us to be better informed in serving the people we care for. And so there is this thing that's kind of arisen, and for people who are attending today, if you haven't ever heard of the concept of trauma informed care, I encourage you to, do some reading and think about it. In a webinar like this, this is an exposure opportunity, and then further, practitioners and researchers and academics have taken this further within the literature and in practice, and created something called trauma-informed palliative care. And so, going from structural vulnerability to trauma, now talking about trauma-informed palliative care. Rami, can you speak to what trauma-informed palliative care really is?
Actually, before that, I would love for Kelli to define trauma. I mean, folks, like you ever watch Netflix and you watch ER, and it's trauma is the trauma unit. It's acute, it's sudden, it's fear-based, it's an accident, it's a murder. But in hospice palliative care, it's not necessarily something that's so acute and so exasperated and so fight or flight. So I welcome Kelli just to define trauma, and then I'd love to speak to my experiences in terms of trauma-informed care and the approaches that are involved in hospice palliative care.
Sure. Thanks, Rami. And, I guess what I would say is that, like a lot of where I speak from, is the people that I work with that experience structural vulnerabilities are people who primarily who are using drugs, and who are homeless or precariously housed and living in poverty. So that's where some of my comments come from. And I guess, what I would say first of all is that there's lots of forms of trauma, as Anna has pointed out, but deep trauma is really often rooted in childhood experiences. And these are experiences where people have had some traumatic events happening for them over time that doesn't allow them to create attachment bonds with people. And, trauma, so in that sense, trauma, as I see it, is something that when we've encountered an experience that is kind of out of our control, it's very frightening, and it disconnects us from our sense of all sense of resourcefulness and safety and love. And there's basically three components to trauma: one, that it's unpredictable; two, that it can't be prevented; and three, it can't be escaped. So trauma is really the root cause of a lot of things, like poverty, like homelessness, like violence. And especially what's important in our context is, and I'll just give an example, many Indigenous peoples, for example, that come into hospital, they don't want to be in hospital because they've experienced so much trauma, either intergenerational trauma, effects of colonization, the residential school experiences, and people really they're traumatized by institutions. So we ourselves, when we see people that come into our care, they might behave in ways that we don't understand at all. And what we find in our research is that, these folks come into our care, and then the providers are kind of like, what's wrong with that person? What's wrong with that person? They're acting in ways that I don't like. They're talking in ways that I don't like. They smell and look in ways that I don't like. We have to recognize in palliative care that we have folks that come to us that have had traumatic experiences, and it's not up to them to help us understand them. It's up to us to figure out how to best care for them. And I know Rami's going to have lots of great suggestions around that.
Thank you. And I'm going to piggyback off of that, Kelli, and even what Sasha and Anna said. Naheed, when somebody is receiving hospice palliative care services, it's how we perceive them. As Kelly said, it's what do we see? Expressions, their behaviors. You know, Dr. Ann Jennings said in 2004 that the prevalence of trauma was at least 76 to 80% of the general public. Now with COVID and 9/11 and all that we're seeing in the world, it's almost 100%. So if almost everybody coming to receive hospice palliative care services experience some aspect of traumatization, and then they have this empathetic, compassionate, safe environment, what happens to that traumatization? It might be presented in front of us, and we don't have necessarily the awareness, the education, or the perception to recognize those expressions as expressions of traumatization. So we judge them. Person's difficult, they're demanding. I've even heard, these are all things I've heard in the field. I get really excited about this because they're called princesses. They're called, too much care. I've actually heard such comments as if, well, if they don't like to die here, they can go die somewhere else. These are frontline practitioners saying it because they don't understand the expressions of traumatization. And something we teach in hospice palliative care, and you know this, Naheed and Sasha, is trauma glasses on and trauma glasses off, right? It's to perceive what might be exasperation expressions of traumatization. And not just that, how are we being received by that person that's experienced traumatization? And then if 100% of Canadians or 90% of Canadians have experienced some aspect of traumatization, do we not bring our aspects of traumatization into the setting, into the people, into the bedside, into their story? Then there's that piece too of it, right? In essence, traumatization, I love what you said, and you hit it on the nose in terms of we have to assume everybody we serve has experienced some aspect of traumatization and apply principles which are called trauma-informed palliative care principles in terms of caring for people, which is, fostering aspects of control, fostering or supporting aspects of empowerment, creating a safe environment, not for us because a hospice can look so safe, but safe for the person we're caring for. Choice, their choice, creating a trustworthiness or recognizing what is not being trusted in the care that we're providing. And then applying anti-oppression, anti-racism, culture safety, culture humility. It's really the approach. We call it trauma-informed approaches to palliative care, and that's yeah, it got me all excited, man. We're so excited now. It's been like 30 years, 20 years. We've been trying to get this out on the national platform, and here we are. So there you go.
What it is, it's a way of talking about issues that are very complicated. It's a vehicle, it's a medium. It is a way of looking and caring for people, an approach to care for people who otherwise wouldn't receive adequate care. And it asks us to be holistic, 360, really think about a person's wholesome and holistic experience. At the outset, it can seem like more work to social and health workers, but in the end, it is really what quality of life care is actually about. We talked a little bit earlier about how trauma can present in sort of non-specific ways, or what it can look like in a palliative care setting. But I'd like to transition to what are some real pragmatic examples of what trauma-informed practice looks like in day-to-day palliative care practice. Dr. Stajduhar, do you have a sense of some examples for us?
Yeah, I mean, I always think, when we come into working in palliative care, we spend a lot of time, encouraging people, think about your own mortality, think about your own experience with how you feel about death. And we encourage, people that volunteer in our programs, if they've come to volunteering because they've lost somebody, we say to them, maybe you need to sit in your own loss and grief for a while. It's the same concept. We actually need, our first order of business is actually to develop our self-reflective practice on things like racism, on things like transphobia, on things like, stigmatization of people. So we have to work. Good trauma-informed care means really continually paying attention to unpacking our own biases, because they come up all the time. And, I could go around and I can say, I'm a very trauma-informed person. I'm not racist. I'm not all these things. Our own racism and classism is invisible. So, and it's invisible to us. So, the first order of business is we need to unpack our own biases and assumptions. And then we need to think about how it is that we demonstrate that to the people that we work with. Because, unfortunately, as Rami say, and Sasha said, I've seen lots of instances of bad treatment, even in palliative care. And, that's palliative care is the place that we, our core raison d'etre is compassion. I've seen very compassionate people not be very compassionate to other groups of people. So we have to provide our own role models. We have to educate ourselves on harm reduction philosophies, for example, which are very consistent with palliative care philosophies, and consider, you know, cultural safety, cultural humility, some of the things that Rami has always said. And to just know that we as providers have all the power in the world to traumatize and re-traumatize people. And so it's really, really up to us to actually be checking ourselves all the time.
That's really powerful. Dr. Stajduhar, thank you. Dr. Voeuk, I'm wondering from your practice if you have some real examples of what trauma-informed palliative care practice can look like.
Yeah, so I think, you know, a lot of stuff has already been talked about by Kelli and Rami, and I just think we need to be aware first of trauma that people have experienced this. But, you know, I think it's, I think in my sense is that we tend to, I think as palliative care folks, we have that approach anyway in terms of how we relate with patients and families. But I think we maybe haven't really named it in the sense that we have to put that lens on, I guess, and look through that lens of ensuring that we are aware that people have gone through trauma, but also ourselves. And maybe that's, and I don't know why, but maybe that can affect why usually compassionate people are not compassionate, because they also have been touched by trauma, and somehow this is their way of expressing it as well. And I think it's important that we do be more intentional and deliberate about it. And so when you say, you know what, I have this in the back of my mind, and I will sort of employ it, I think active listening and acknowledging the patient. And I don't think we actually have to say, you know, we don't have to totally understand what's going on, but as long as we acknowledge what they're saying and their stories and what they've gone through, and that, you know, to validate them and to say, you know what, you aren't to blame for what has happened, right? This is not your fault. And how can we work together to try to, you know, move forward in this? So I think the key thing is also is just to create the safe environment. And there's one thing of our perception. We may feel that the environment is safe. You know, a hospital setting to us, that's our playground, right? That's where we work, or whatever hospice setting. We're used to that environment, but when someone else is coming in, it may not feel safe. So what does that mean? So if you know, barriers such or cultural sensitivity, I think, as we were talking about earlier, is important. So, you know, if English isn't their first language, try to get an interpreter or translator or a language line, or if someone can't hear properly, get a pocket talker or something to make them feel more safe and not relive or re-traumatize, as was spoken earlier.
Thanks, Dr. Voeuk, and thank you all for the amazing comments that are coming in. I'm doing my best to navigate the multiple panels. You are all so kind, and we really appreciate that this is impacting an area of care that you care about. Clearly, a group of compassionate people have joined this webinar. As we segue, we've talked. I appreciate the conversation, guys, but it's been sort of high level up until now. It's been talking about definitions and contextualizing structural vulnerability and trauma, and I think that's important. But at the end of the day, this is about care, and this is about improving care for people in our communities on the front line. So I'd like to do some deep dives on particular issues that I think are very relevant in our communities coast to coast, no matter where you are. The first dive I'd like to do is specifically to talk about trauma and its impact on homelessness. We live in a country where yesterday the Canadian Alliance to End Homelessness released a report that showed that nearly 1/3 of Canadians have either experienced homelessness or know someone who has, and 1.6 million Canadians have experienced homelessness. This is the result of that report. And so it's important to recognize that that has impacts on access to care, but also access to palliative care. So this question goes to Rami, and then we'll go to Sasha. It's a two-parter. How does trauma impact homelessness and care, particularly around palliative care access, and then advanced care planning?
You got an hour, a couple hours for me to speak to this, but Naheed, I mean, your entire program, Peach, and Simon's program in Calgary, is why this all spawned. And I'm going to focus on what I really know, which is the access to, or lack of access and barriers to hospice palliative care for people living with who are living in experiencing homelessness or structural vulnerability. My experience isn't as much with ACP and homelessness, but I kind of want to take a risk and say, a lot of hospice palliative care services have a great deal of barriers to accessing, or for people who are experiencing homelessness to access their services. And it starts right from where even the hospice programs are built. They're usually in affluent neighborhoods. Most hospices, especially residences, are built in areas where fund development, fundraising can thrive the hospice. So what does that tell you? You're not going to see a hospice in a poor community. Look it up north, right? Where are the hospice programs up there? So that's one piece, is right. The structure of hospice palliative care in and of itself doesn't lend itself to being accessible to people experiencing homelessness or structural vulnerability, for the very essence of why it's built or how it's built and how it's sustained. And then we move to the intake process. Let's look at where actually the intake comes from. I mean, that's where you had to go into the community, Sasha and Naheed, to serve people experiencing homelessness and apply palliative care for them, because those people could not come to a hospice setting, nor would, let's be straight, nor would our care coordinators or intake coordinators or case managers go to those settings, because truly they're no-go zones. So how are those people going to access services, right? Then there's the whole harm reduction piece. I don't want to steal anybody's thunder here, but most hospice palliative care programs toot themselves as being, you know, managed alcohol programs, but in essence, some of them have gone to abstinence models. So they're not even harm reduction practices and policies in place to break down the barriers for coping mechanisms that are used by a lot of people experiencing homelessness to get services for hospice palliative care, right? So there's a barrier right there in and of itself. I know a hospice that, at least at the time that I was there, you know, people could, you know, use alcohol on site, and then all of a sudden, or smoke, you know, in a particular area. And now it's complete abstinence model because it's easier care, it's safer, it's not as risk laden. These are all barriers. And so we serve a very small proportion of the population because of all these barriers we create with respect to access to services. So I think also when it comes to autonomy and self-direction, we've heard this from some of the research studied out in BC and Vancouver. Why do I have to be dying for you to care about me now? Right? Where was the housing before that? Where was the supports before that? Why are we looking so downstream to provide hospice palliative care for people who are experiencing structural vulnerability and homelessness? Why are we not looking upstream? Because I love what you say, Naheed, and I know Sasha, advocates for this, is that homelessness is a life-limiting illness. So that's, and one more piece I'll add to that: the trauma experienced by one night on the street is akin to the foundational pieces that spawn trauma-informed care.
Thank you, Rami. Really powerful. Sasha, what are your thoughts?
I think some of the biggest barriers for me for access to healthcare or palliative healthcare are very simple things that people just really healthcare is simple things like, are these medications going to be going to get to their radiation? It's not affordable. That are pretty simple. Like, I would say that I can't tell you how many discharge summaries I've seen that said, have this patient call so-and-so to book a new. So how is that going to happen? I think like the simple barriers in palliative care are really the biggest barriers, to be honest. In terms of advanced care planning, I can't tell you how many, like you, Naheed, how many funerals I arrange for individuals because they simply don't have anyone that they would trust enough to be their substitute decision maker or power of attorney. So it ends up going down to like public guardian and trustee, or locating family that really doesn't want to be a part of those discussions, and they say, no, I don't want any part of this, and then it comes back to us. And luckily we have people on our team that are willing to do that, but in a lot of situations it's just kind of like there's no one there to make those advanced care planning decisions, no one to make funeral arrangements, and those individuals kind of sit at the coroner's office until they have done their due diligence to find out if there's any next of kin, and that can sometimes take up to a year, and that is heartbreaking to me. So that's why I always offer to make funeral arrangements. But yeah, it's really challenging, a lot of challenging situations with access and advanced care planning decisions.
Yeah.
Can I just add on to that a little bit, Naheed, and just to we're doing quite a bit of work in Victoria right now around advanced care planning with populations, and we have quite an engaged kind of community collective of people. And you know, I think one of the things for us, you know, that we've really learned is the people that have most connection with the people that we work with are housing workers, outreach workers, and we're actually working with them. So and really trying to move things upstream. You know, and we'll be in a place to share everything that we've been developing. But, you know, I think the thing is that often people are estranged from their family, and often their family are really chosen family or street family who often get completely disregarded in conversations when these folks actually know quite a bit about people as well as their workers. So I think for advanced care planning, we can't take things and tools from palliative care and plop them into this population. It requires adaptation, and it requires a palliative approach, early upstream intervention, adaptation of things that we know from palliative care to the context of the population we're working with. And we can do that with advanced care planning. But I will say, and it's one of the things that I think is so very important, is this is relational practice at its finest. And you cannot expect and assume that if somebody who experiences structural vulnerability is in your care, that they're going to trust you just because you're a doctor or a nurse. No, it actually takes buckets of time to develop and establish trust with people, because they, to a large degree, have really not experienced trust in their interactions with formalized healthcare. So I'll stop there.
Well, that's fabulous. And for those who are not familiar with Dr. Stajduhar's research, a report that her team put out in 2018 called Too Little, Too Late really speaks to many of these key principles, including flexibility around that as well. So that was a really, I thought, an interesting dive. And I do talk about this a lot, but I still thought that was really interesting around homelessness and trauma and palliative care. I'd like to just segue a little bit to talk about people who use drugs. I live in a province in Ontario where currently 55 people are dying from overdose every single week. I know that the numbers are similar and sometimes worse in British Columbia. We are seeing an overdose crisis across this country. And so when you think about trauma and people who use drugs, especially in a COVID context, I'm going to ask Dr. Stajduhar, then Sasha, a question. How does this work particularly around prescribing? Because in palliative care, we do prescribe controlled substances to alleviate symptoms. And how do we deal with the overdose death epidemic? Dr. Stajduhar, your thoughts?
Yeah, well, these are big issues in my mind, because we actually, I think for the third month in a row, we have more overdose deaths in a month in British Columbia than we've had total COVID deaths in our province. So it's a very discouraging thing. So I'm going to just talk about the prescribing thing first, and then the overdose thing second. And I'm not a physician and I don't prescribe, but what I know from my physician colleagues that I work with in palliative care is that they're very nervous about prescribing for pain management, particularly for people who have addictions. And, you know, and there's a lot of hesitancy, and there's a lot of people who, you know, still are being seen as drug seeking, and, all that I can say around that, and the physicians on our panel might have more to say, but our physician in our port team in Victoria and our nurse spend a lot of time coaching, mentoring, you know, helping people to feel comfortable, because at the bottom line is that people deserve to have their pain managed. And just because you are a person who uses drugs doesn't mean that you're not deserving of having your pain managed, whatever your pain happens to be from. In terms of the overdose epidemic, overdose deaths are completely traumatizing. If there is anything that we can say, that is a traumatizing death experience. And imagine also what it's like to watch your friends die, preventable deaths. Because actually, if we didn't have a poison drug supply in our country and we had a safe supply for people, people wouldn't be dying. So imagine what it's like to have your friend die from something that is completely predictable. And this is what Rami gets excited about something. This is what I get excited about. I'm so frustrated that actually I'm seeing friends of mine die because they can't get a safe supply of drugs. And again, it comes back to, you know, all our societal views around drug addiction. And, you know, I'm just going to say one last thing, because I could go on for a long time. I think it was maybe 3 or so years ago with a colleague of mine, we published an op-ed in the Globe and Mail, and in that op-ed was a call out to the palliative care community. I don't understand. This is a situation that is a catastrophic loss in this community, and there is nobody that knows loss and grief better than palliative care. So I don't understand why the palliative care community is not responding to this loss. So sorry, I'm getting, I'll be getting very excited and upset soon, but it is absolutely what we need to do.
Well, thank you, and thank you for that compassionate call to action. These are very trying times, and you know, we've coordinated a public health response around COVID, but we have not coordinated a public health response around the overdose death crisis, which is a public health emergency. Sasha, your thoughts on how trauma impacts people who use drugs?
I will say, like, from a nursing perspective, some of the prescribing concerns are obviously very serious. Been as a how to or not to make them feel like they are being treated differently because they use drugs. And sometimes that is a simple, you know, I'm here to count your medication because we need to see if you need more. Or that is what I do in terms of kind of destigmatizing the people who use drugs role, especially with nursing, because for a lot of nurses, it's a new skill. It's something they haven't had to deal with before, and they don't know how to communicate with people or how to. It's really challenging. Secondly, overdose deaths, they're really traumatizing, even for our team. They really are, because you always wonder, did we do something wrong? Did we not prescribe enough pain medication to make them comfortable so they went out of their way to do this? And even though that might not be the case, I think you, as a healthcare professional, you're always wondering if you could have done something better. And it's really hard. It really is. I mean, we're lucky that we have, on the Peach team, we do grief circles that involve people in the circle. Personally, it's very challenging to have somebody who dies of an overdose, even though that you, especially when you're providing palliative care for them, it can be rough.
Thank you, Sasha. I'm having some technical difficulties with Sasha. Thank you, everyone, for letting us know.
I think it's just also important, Naheed, to say that on that last note for Sasha is that then it becomes traumatizing for us as workers. And that's what we see in our work in the inner city community as you know, we see people themselves who are structurally vulnerable, traumatized. We actually see the workers, including people in our mobile palliative care teams, that also experience trauma as a result of being witness to very, very unjust circumstances. It's not a good thing to be watching somebody die in an unjust way.
For sure, high rates of moral injury. We see high turnover among the staff, and there aren't always mechanisms in place to support people through these experiences. Very passionate. Thank you all for your answers. We have lots of comments coming in, lots of positivity. This is clearly touching people in very different ways, and we appreciate your comments. If you have a question, please use the Q&A function so that we can actually address it in the live Q&A, which is coming up soon. As we round out our question period, period, and we'll start to open things up shortly. This question goes to Dr. Voeuk. As someone who works with people who are refugees, asylum seekers, new Canadians, and migrants, what are the experiences of this group of structurally vulnerable people, in terms of their access to palliative care? And we do live in a world that is changing geopolitically. Migrant health and the status of migrant people around the world has changed a lot with a lot of the politics that are going on below us, south of the border, but also around the world. Wondering what your thoughts are around these issues.
Yeah, thanks, Naheed. So I guess how does trauma impact all of the named groups that you mentioned? And I think the simple answer is it depends. But I think it's we have to be cautious not to overgeneralize, particularly into groups of people, but then also experiences as a population and then where they came from initially. So for example, if we talk about refugees, their experiences are going to be much different. And I'm going to give a few different definitions, and that might help to kind of think about potential traumas that they might have experienced. So for example, refugees are someone who's forced to flee their country because of persecution, war, or violence. And that's going to be quite different from someone who is an immigrant who has sort of chosen to come without that particular stress. In addition, an asylum seeker is similar to that in that they are looking for protection or refuge as well, or asylum, but they haven't had a legally determined claim for refugee status. And then you've got your migrants who are, I would say these are more temporary kind of movements. So example, temporary foreign workers that we see in BC and Ontario. And then you've got people who are stateless, where their host country or their home country doesn't recognize them, but then they try to go to another place and they're not recognized. So think about how you would feel if you were stateless, you don't have a home anymore. And so I think it's really difficult to overgeneralize, but I think it's important to recognize that there are significant differences within the groups of people themselves and where they're coming from. So in terms of palliative care and their access, I think if you can think about, it's hard to think about all of the things that people have gone through, but perhaps that may be impacting, some of the symptoms that they're experiencing. Why do we have complex cases, or why do we have difficult to manage symptoms where we talk about whole person care and total suffering or total pain? So your pain is not just physical, but how much of this has been impacted by what you've experienced as a child and all through life even. And that, again, we talked about intergenerational trauma, where if it's not affecting you directly, it might be affecting you indirectly. For example, your children or your parents. And so I think there's lots to think about. This could be, now this is something that I get passionate about in terms of, getting excited, but yeah, this would be a much longer, I think, webinar if I went further into it. But I think it's just to be aware that there are differences and that it can actually affect some of their symptoms, and how do we best as palliative care people try to understand that they may be going through something difficult, and how do we reduce their suffering and improve their quality of life.
Yeah,
Hey,
for sure.
Can I add one small piece to Anna,
Please,
just very quickly? Anna, you brought up something that I just wanted to highlight. Even how we define homelessness. If you look at the great work by Jesse Thistle, okay, in the Indigenous definition of homelessness and the thesis that he did on it, there's a very much broader definition that could be, explained by homelessness for Indigenous peoples, let alone for peoples who are coming here as refugees and immigrants. So I'm so happy you brought that up, and I think we need to speak to that at one time, and maybe we'd invite Jesse Thistle to thank you, Naheed.
No worries. Yeah, no, absolutely. The other issues to consider, and Sasha and I and our Peach team in Toronto deal with this all the time, is particularly around assumptions in care. The community palliative care assumes you have people to care for you, a roof over your head, some money, but also health insurance, right? So people who are asylum seekers, who are refugee claimants or failed refugee claimants, they all have different insurance statuses, and sometimes they don't actually have health insurance. And so without without health insurance, you don't get home care. And I know that Sasha's built a real expertise in working on compassionate home care. And often our team, which is not by definition home care in our local community, has had to take the role of home care because they're not getting provincial coverage. So coverage is a major issue when dealing with these populations, and in addition to many of the issues that you mentioned as well, Dr. Voeuk. So thank you so much. This is great, lots of excitement. Everyone's getting excited about one thing or another. So we've had a pretty busy Q&A room, and I apologize, like it's been very busy. I'm going to just start working through some of the questions. We have about 10-15 minutes to work through some of the questions. I'll do my best. Please keep them coming. We have a question that's come in around our region is exploring opportunities around trauma-informed bereavement support for individuals who are structurally vulnerable. Would love to hear your ideas about that. I wonder if Dr. Stajduhar can speak to that.
Sure. I mean, I think anytime that anybody wants to help is a really good thing, and I think it's how to best help. And it's number one, I think it depends on the population that you're working with, and I can't give you an answer because it really depends on your context and your relationship with the community. We have lots of people, like I have lots of people emailing me to say, we want to do something like what you're doing in Victoria or what they're doing in Toronto or in Calgary, and like, give me the 5 steps for how to do that. But and all of the programs have grown up in very different ways, but I think with some really core elements. And so I think, if you want to start a bereavement service, you really first need to get to know the community of people that you're seeking to serve. Because I think in our really well-intentioned efforts to want to help people, we actually miss what their own strengths and what they can do themselves. So the way that we think about bereavement support and the work that we're doing in Victoria is we're working in very close connection with the inner city communities to talk with them about what it is that they think needs to be done. Not what I know about how to give bereavement support, but it doesn't mean that I'm the right person to do it. And it doesn't mean that what I know from my mainstream palliative care lens actually is going to be well received by whatever community you're in. So again, it's kind of thinking about, at least in the communities that I work with, that very, really engaging, listening, learning, and co-developing and co-producing. Because I can tell you that the kind of PowerPoint seminar on bereavement is just not going to work. I mean, that would be my own approach. Very community development kind of iterative kind of way, because otherwise we run the risk. And there might be in your own communities, like in our community, we have a few people who are very well respected in the community, who have counseling backgrounds, who might not work in palliative care, but they really understand this community. And that's a really, really important thing to consider, because just because we're palliative care providers and know about bereavement doesn't mean we understand the community.
Totally, and the community that you serve, Dr. Stajduhar, you've done an excellent job at kind of community engineering a community-based response in this regard. And for those who are interested, please check out the Access to Care Twitter account that Dr. Stajduhar and her team runs. I'm going to put this question towards Sasha. A really great question. There's some people are wondering the street family thing, this informal caregiving. What's that? Can you speak more to how informal caregiving and grieving presents for people who are experiencing homelessness?
Yes, definitely. I mean, street family, especially with individuals whose biological family to life, most of us have our own kind of prescribed family that we have chosen versus what has been given to us through our bloodline. And we actually hold those people close because we chose them. They weren't just automatically biological. And these individuals in the street family, they actually take so much pride in taking care of the people who are, in my experience, who are palliative and dying, and have actually will do more than like we can actually provide through home care. They will do bathing, dressing, medication pickups, and they really are truly family. And not only does it help the individual, but it also gives the person helping an actual sense of purpose. And when it's all said and done, we've heard people saying, you know, that was the best thing I could have done because I felt like I gave back. I felt like I did something for someone. That's the best I felt in a long time. And in terms of grief and bereavement for street family, that's really challenging because quite often the estranged family who is now legal next of kin can kind of swoop in and take over everything. But really, there's nothing done for the street family who really need to grieve. So we, in the recent past, we've been trying to do like informal memorial services in places that were close to the person who passed away, and include their street family. And it's been really helpful. You can see how much they grieve and how much they actually needed an outlet for grief. And it's been really, it's been helpful. It's been really helpful and nice.
Great. Thank you so much, Sasha. That really brings it to life. We have a question around grief and bereavement. So Rami, the palliative care philosophy includes grief and bereavement. How is the palliative care community of practice supporting vulnerable populations along their grief journey? You work as a consultant, have worked in various places and spaces in community and hospice. How are we supporting the grief journey and the bereavement journey around structurally vulnerable people in our communities?
Very simply, not appropriately, honestly. And there's little pockets of what Peach does and what Kelly spoke to and what Sasha does. But you know what? We're trying to take a model that doesn't fit. We're trying to take these principles of grief and bereavement and apply them to a population that has experienced homelessness, structural vulnerability, and trauma. And I'll give you an example, folks. You have this traditional, I run grief and bereavement groups, I run caregiver groups. You take these models and where it's, you know, people come and they create a safe space, and we have this whole program with which to explore or you know, speak to experiences of loss and grief. Most likely these populations that we are serving who are experiencing structural vulnerability and homeless have experienced so much loss. Death is the next day around the corner. They live with death and dying every single day. The traumatization, when it's expressed as hypoarousal, affect dysregulation, hypoarousal, right, and attachment difficulties, then the group or the grief and bereavement model doesn't work, right? We have to change it. I love what you said, Kelly, in terms of it has to be other driven. We can't drive this in terms of grief and bereavement. The other thing I wanted to mention that Anna and Sasha spoke to, folks, oftentimes we talk about homelessness and structural vulnerability. We assume they're, for the most part, maybe not in this group, that they're white. But you know, I work a lot on the streets in terms of certain other social service programs. So much of our populations of refugees that have come to Canada are living in shelters on the streets. Now, we did a project with Lighthouse for Grieving Children on multiculturalism and diversity and grief and bereavement. You know, most of these cultures, most of these ethnicities that have come here don't necessarily have the language of grief and bereavement. They don't talk about loss like me and you. We don't talk about loss as we do in North America. We have a very diverse population in Canada. Southern Ontario is very rich, but we found in 2 years that they don't speak the language grief as we speak it. So how are we going to support them in their experiences of loss and grief if they don't even have the same words in the languages that they speak to define grief and bereavement? So it goes back to what you said, Kelly. We have to look at them to see even how the language is how language is used and how trauma infuses that language and expression of their losses.
That is such a powerful point. And, here in Toronto, 2/3 of people experiencing homelessness are Black, Indigenous people of color. So there are various intersections around this conversation. I do want to say that we've mentioned and talked about Indigenous issues in palliative care here and there in the session. This is an issue that deserves its own session, and Pallium will be hosting its own session, as it should, on this topic. And so we have left some of the content around that to matter experts who will speak later at a future webinar. Our last question, and I'm sad because we we do want to go to a closing. We want to close this out a little bit. Goes to Dr. Voeuk. COVID has been a wild time for everybody. And we are aware that COVID has impacted our health systems, but how has COVID impacted palliative care delivery, particularly for structurally vulnerable people? And if you can look to the future and what your thoughts are around that, that will be really important as well. What are your thoughts?
Yeah, no, thanks for that question. So yeah, I think palliative care delivery, and I think it's certainly shed a light on palliative care because, you know, people have been dying either at, in our setting anyway, mainly at home or in long-term care settings. So I think there, you know, that awareness is there, and it's a great time for us to be able to take that opportunity to talk about advanced care planning and about early integration of palliative care. And for the future, I mean, it's difficult to say. I think it's more, I think we still need to build awareness around what palliative care is, and you know, to ensure that people are willing to accept it and not be afraid. Actually, you know, it's not just about death and dying, but it's about living well until you die, and that they don't have to suffer. So, I mean, hopefully, I mean, there, you know, if we always talk about needing funding, and we need personnel, and we need all these things. So I think we do need to work together to try to bring this forward. But it's hopefully it's only going to get better, and more people will get access. But it is we do live in an interesting set of times right now.
For sure, absolutely, guys. I want to bring it, try to bring it home. I have a question. It's a deep question to close out today's discussion. No pressure. So, you know, we have a lot of people in attendance. Many people will watch this as a video later. Lots of comments and questions have come in. If you had one piece of advice, one thought that you would provide for people who are interested and want to provide palliative care for structurally vulnerable people through a trauma-informed lens in their communities, what would that one piece of advice be? We'll start with Dr. Stajduhar.
I could probably say, I have two things to say. One would be shut up and listen. Listen to the people that are in front of you and that you're caring for. And really try to look at people who experience structural vulnerability and what they can teach you about resilience and strength and love. That's what I would say.
That really hits home. Sasha?
I think I would say never assume. Always ask your patients how they, and never assume that they have the means to go about typical healthcare and typical, if you had substantial amount of money. So just always never assume that people have money. Never assume that they have a means to get their appointments. Never assume they have means to get their medications. Always ask, because that can be the difference between life and death.
True. Rami?
Here's the home run, Naheed. Hospice palliative care services across the country cannot begin to serve people experiencing structural vulnerability and homelessness unless they become trauma-informed. I'm going to put a call to action out there to the local leadership in hospices, to the executive directors, directors of care, to the provincial leadership, the CEO, and to the national leadership in hospice palliative care. Let's make our hospice palliative care settings and all the domains that are involved in those cares, caregiver support, bereavement, frontline, hospice volunteers, staff, trauma-informed. Let's make our centers trauma-informed. And then we have broken down our own. We looked, as Kelly started us out, we looked at ourselves to see where are we creating the barriers before we actually are even thinking about serving people who are experiencing structural vulnerability or homelessness.
Thank you. And Dr. Voeuk, your thoughts?
I would say, you know, be intentional, be deliberate, and put on those trauma lenses, so to speak, when you go and see someone, so that it's sort of, you know, on the radar, and also to integrate it into your practice. We talk about integration of palliative care. We don't say, you know, it's not an additive extra work thing that we have to do, but it's something that should flow naturally. And so I think it's important to integrate it in the continuum of care that we provide for patients and their families. And yeah, thank you.
That's great. I'm kind of sad, guys, because we're coming towards the end of this session. Thank you so much to our panelists today for this thought-provoking, stimulating, and vital discussion on the impact of structural vulnerability and trauma, particularly as it impacts palliative care access and delivery in our communities. I really appreciated the evidence-based conversation, but most importantly, the way our panelists dissected the way that the deep roots of systemic inequity are entrenched within every asset of the structures or facet of the structures that deliver healthcare. Thank you for your personal reflections and for everything you do every day to serve our communities. To our attendees, who I know work so hard to do the work that they do, for your questions, your comments, and I know this is just the beginning of a movement, and I know we will keep this moving. I want to thank Pallium Canada, the Canadian Society of Palliative Care Physicians, and our partners, our incredible teammate Stephanie Ferris at Pallium Canada, who did such a fabulous job in coordinating this webinar and bringing it all together. Also, thank you to Salwa for your efforts as well. Once again, a reminder that we are sending a link after this webinar regarding the CPC exchange that's being hosted by Pallium Canada and the Canadian Society of Palliative Care Physicians, and that email will guide you to how to get linked to that. With that, thank you all so much for joining us and being part of today's session. Have a great night and have an even better weekend.